with some question and prices. I have two 50s, 50 and 50. So if you want the 50 real, stay awake. If you want to sleep, just don't snore, please, so don't disturb the others. Okay, maybe now you recall a case that you have seen. I'm sure all of us who work in the NICU, they have seen this nightmare at least once in a while. This story happened in our NICU actually, but many years ago. They were 28-week twin from Syria. They were admitted to the NICU, 900 gram, intubated, ventilated for a few days, received prophylactic, received the routine care, and had initially a smooth course. Actually, and this is one of the challenges sometimes, especially when you talk to the parents, you reassure them, everything is going okay so far. But that's why I always tell them it's a long road. So, and there are a lot of humps in the road. So we cannot really be sure until you take him home. Then usually they ask, when will be the discharge? The discharge when the baby is ready and you take him home, you reach to your car and reach your home, that's the time you can say discharge. One of them was 1.750, our discharge criteria is 1.8, so we were just waiting for the discharge weight. I came for night duty, the baby started to have tachycardia. In few minutes, tachypnea, mottled skin, we were simply crashing. Please pay attention to the bold words. It is written there, this way, because there is a message behind. Move to upper resuscitator, full septic screen, IV bolus, IV antibiotic, blood gas should metabolic acidosis, needed IV fluid by car, ventilated, and within the hour he was ventilated, he had hypotension, inotropes. So what do you think is the microorganism there?
What was the age?
He was like 2 months.
2 months. Late onset.
Yes, late onset. Gram negative? Group B, okay. Actually, everything can be annual. Okay, it was Klebsiella. Baby went to full septic shock, needed aggressive management. The family were updated daily that the outcome will be poor. I remember her shiny skin and then oliguria, edematous. We really, I don't say we lost hope, but we were really very pessimistic at more than one time. And then the treatment, luckily the baby responded and discharged home with no permanent issue, alhamdulillah. Those who love poetry, sorry, I cannot translate. الناس بالناس ما دام الوفاء بهم والعسر واليسر ساعات وأوقات وأكرم الناس ما بين الورى رجل تقضى على يده للناس حاجاته لا تقطعن يد المعروف عن أحد إن كنت تقدر فالأيام تارات واشكر صنيعة فضل الله إذ جعلت إليك لا لك عند الناس حاجات قد مات قوم وما ماتت فضائلهم وعاش قوم وهم في الناس أموات. I always remind myself with this. Every time I get a call from parents, sometimes you get too many calls at the same time, sometimes very frequent, and sometimes very makulit, as they said, our Filipino girls' parents. But always remember, واشكر صنيعة فضل الله إذ جعلت إليك لا لك عند الناس حاجات. We move to story number 2. He was 35 weeks, admitted to NICU. He had CPAP, then mechanical ventilation due to respiratory distress, blood gas, and blood gas result. Reached moderate setting, chest X-ray wasn't significant, still desatting. Cardiology consult, no cardiac lesion. CBC within normal. First CRP was negative, second CRP was 6. Blood CS. GBS. That was early onset. GBS. GBS is one of the leading causes, and it can be early and can be late. Early in the first week, and it is a leading cause of sepsis in neonate, can cause pneumonia, meningitis, and acquired by fetus in utero or during birth. That's why there is screening for the moms, or can be late onset, 1 to 4 weeks, and could occur up to 3 months. There are a lot of clinical presentation: spectrum, meningitis, sepsis, arthritis, osteomyelitis, pneumonia. The third story, actually, it started here but ended somewhere else and then came back to us after all the. That was also many years ago. He was 7 days, came to ER with fever, poor feeding, decreased activity, seen by pediatric registrar, advice for admission, but the father signed AMA. Perinatal history was not significant. He came the second day to another emergency room with high fever, no feeding, vomiting, drowsiness, mottled skin, admitted to an ICU, full septic screen, resuscitation, antibiotic, supportive care. His lab with high CRP, high WBC, and we knew it from the report when he came to us later. He had meningitis, blood and CS culture, Staph aureus, complicated by ventriculitis, ended up blind, deaf with hydrocephalus. He was shunted and had complicated shunt with many infections. He was admitted many times. Father carried the guilt feeling all along, actually, and he expressed his feeling by hating all of us. And then he wrote many complaints reached to the king. Died at 4 years of age, unfortunately. The last story, full term, admitted with meconium aspiration syndrome, ventilated for a few days, needed high frequency oscillation. In a few days, he showed improvement, sittings came down, feeding started. 3 days after feeding, there was feeding intolerance, just like Dr. Rizan talked about it just before me. Abdominal distension and vomiting. Septic screen CRP was not very high, 39. CBC was normal. And all cultures, blood, urine, CSF were negative. And he improved after antibiotic treatment. What did we learn from these stories? Anyone awake? Other than Dr. Fawzia, because it seems he was the only one awake. Salamat, man. She's not feeling very well. Okay, sepsis is a nightmare. It's a true nightmare, and no single sign or symptoms. You know, it comes with hypothermia, hyperthermia, hypoglycemia, hyperglycemia, hyperactivity, low activity. It could come, contradiction signs. There is no single lab. You might have positive culture, you might have abnormal CBC, you might have completely normal CBC, completely normal CRP, and negative culture. So there is no single lab that will guide you, or will tell you, you can swear on it. You need high index of suspicion. It's very important prompt recognition. We need to recognize as soon as possible and prompt action, because it's not useful for the baby if you recognize but you do not act. And always, better safe than sorry. يعني ايش بالعربي؟ احتياط واجب ولا؟
الاحتياط ولا الندم؟
الاحتياط ولا الندم؟ احسنت دكتور. دكتور لازم تاخذ جائزة. And also, always, we never lose hope, because we never know what tomorrow may bring. When we deal with neonates, we don't lose hope. Sometimes we reach, up to almost we feel that we lost the battle, but then we come out. Especially if they are girls. Girls are survivors. Who are the frontliners to fight neonatal sepsis? No, other than the resident. No, the resident will come only if they have rotation. our NICU nurses. They are the frontliners because in their hand we have the fate of these small babies. This picture is for our old staff, and then some of them they left. And we have our new generation. I couldn't get a picture for them because I finished my presentation at 10 o'clock in the evening, but I have some of them here, Safa, Naram, Wafa, Hadil, and Hanouf. Thank you very much for all that you do. We have Maya, our charge nurse, the new nurse in charge. Thank you very much for you and your team. How to prevent? Can we? Unfortunately, it's actually, most of the time it's preventable, but sometimes really you cannot do anything. We need strict hand hygiene protocol, and here again we need the nurses, actually, because we need to remind us, and never ever be scared to remind the doctor, and to remind him once and twice and thrice. I remember we had a head nurse, he is from UK, and then doing a procedure when she was there, as a junior resident, it was really a nightmare actually, because change your gloves, you touch the resuscitator, no, you drop something. So she was very strict really. So we need strict hand hygiene protocol and follow the infection control protocol. Also, we need to use antibiotics wisely. Start the proper antibiotic and stop at the proper time to fight for the antibacterial and also the superbugs, the bacterial resistance. This is from Pete's case notes. I know it's very busy. I will not read it, don't worry. But this is for those who did not like my stories, who they might have here. You can see here the history, prenatal pregnancy and birth history, and the physical exam, investigation, and risk factor. And this algorithm is very good. For those who want it, you can have the presentation, or you can have also. It is available with its cases notes. We usually start with, does the baby appears unwell? If yes, we need prompt investigation for septic workup. If no, we ask ourselves another question. If the mother is GPS positive, yes, so other risk factor, yes, so we go to individualized investigation. If no, any other risk factor. If yes, again, if you notice here, we always take the precaution side, which is very important because, again, it is safe better than sorry. There is a calculator also, I found it when we don't use it actually in our unit, but it calculates in neonatal early onset sepsis calculator for babies more than 34 weeks, and then you put the incidence of early onset sepsis. It is dropping list here. There is a CDC. It depends on your unit, and if you don't have, there is a CDC. And then you put the gestational age, high maternal antepartum temperature, ROM, how many hours of rupture of membranes, maternal GPS status, and type of intrapartum antibiotic, if she received prophylactic antibiotic or not, and then you just press calculate. It will calculate for you here what is the risk factor, and then what are the clinical recommendations, and how frequent you need to do your vital signs. I think I'm coming to an end. Take home message. Sepsis is a hidden ghost. Be extra careful. If you are in doubt, remember the previous stories. Follow your unit guidelines for investigation and treatment. I used to joke with the nurses to this. Add sepsis to your name. You had a nurse before, Anna. So if somebody asks you what's your name, you should say Anna Sepsis. So. I have special thanks to our NICU graduate. We have Miss Reem here. She was our NICU baby as part of the twins. I don't know how many years ago, I won't say. So she designed this presentation. Thank you, Reem. Now we have question and prizes.
Now the people will awake.
Okay, so those who are awake. Okay, the first question is, What's the definition of late onset GBS sepsis? And what are the signs? It is in the picture, you know, the baby in the picture. Dr. Fawzia, please wait for them to answer. You will answer the second question. Father,
Onset of sepsis from the age of 1 week to 1 month with blood culture indicating the presence of disease.
okay, so what are the possible, I know that there's a wide range, but what is mentioned there?
The symptoms of sepsis may be hypothermia, hyperthermia, the baby is not doing well, may present by picture meningitis.
Does he deserve the prize or no?
Yes, yes.
Yes? Okay, Father, Father. No, I'm serious, you know, I have 250s, I brought it. You know, nowadays you are using cars to pay, but now you have to. أنا هيك دكتور. أهلاً واحد. تفضل. شكراً. Okay, second question is for those who are very observant. What is the color of the shirt of the baby in the neonatal sepsis calculator? You know she was carrying a baby? What was the color of his shirt or her shirt?
Orange.
Pink? Orange? Blue? Yeah. Cream لا طبعا she knows most likely. Maya.
Sorry, without share.
So, who said yellow? Yes. All right, it was yellow. Come. Arwa, come. Thank you, Arwa. Arwa, one of our new NICU staffs. And she's working with us for the last 7 months, 8 months now. Okay, I think now I came to an end. The question I think will be during with the panel later on. Thank you very much, and this is Twitter and email if you want any questions. Thank you.